Hello, in this lecture we'll be talking about the alterations of your thyroid gland. So specifically we'll be talking about your hypothyroidism and hyperthyroidism. Before that, I would like to give an overview on the anatomy and physiology of your thyroid gland. Notice the location of your thyroid gland, which can be found on our neck. So for that reason, during assessment, we usually ask our patient to swallow from a glass of water to ensure or to palpate, effectively your thyroid gland. Okay, there are two ways for you to palpate the thyroid. You may be facing the client, but more effectively, you can stand behind the client to palpate the lobes of your thyroid. So notice, class, that your thyroid is in close proximity with your parathyroid gland. Notice that the parathyroid gland is in fact located behind your thyroid gland, which means that any surgery in the thyroid could possibly affect also your parathyroid gland. Okay? Now, let's talk about the hormones. Your thyroid gland releases your T3 and your T4. So, the release of your T3 and T4 class is controlled by the release of your TSH or your thyroid stimulating hormone from your anterior pituitary gland. Again, the thyroid gland releases your T3 and your T4. The release of the T3 and T4 from the thyroid gland is controlled by the release of the TSH or thyroid stimulating hormone, or also known as thyrotropin, from the anterior pituitary gland. The relationship between TSH, T3, and T4 is governed by your negative feedback mechanism. Whenever, class, there is a decrease on your T3 and your T4 levels, class, whenever there is a decrease between T3 and T4 levels, your TSH would try to increase in such a way that your thyroid stimulating hormone or your thyrotropin will stimulate the thyroid to release T3 and T4. So once the T3 and T4 levels are already increased, your TSH would be decreased in such a way that the production of T3 and T4 from the thyroid gland would also be decreased. Okay? Until they're balanced out. So class, your negative feedback mechanism. Other than that, another organ involved in the control of the amount of our T3 and your T4 is your TRH. So your TRH is your thyrotropin releasing hormone. Your thyrotropin releasing hormone is released from the hypothalamus. Your TRH or thyrotropin releasing hormone is secreted by your hypothalamus. It is the one that triggers your anterior pituitary gland to release your TSH or your thyroid stimulating hormone. Okay, so let's combine all of them. Hypothalamus would release TRH. TRH would trigger anterior pituitary gland to release your TSH. Your TSH would trigger your thyroid gland to release your T3 and your T4. Okay? Environmental factors would usually affect the release of your TRH. An example would be a decrease in temperature. So class, whenever there is a decrease of environmental temperature, for your body to compensate, your hypothalamus, our thermoregulatory center of the body, would release your TRH to tell TSH to be released such that T3 and T4 will be released in such a way that the basal metabolic rate would be increased for us to survive the cold environment. Okay? Let's talk about your hypothyroidism. There are several causes for your hypothyroidism, classified as primary, secondary, and tertiary. When I say primary hypothyroidism, class, this is brought about by the congenital defects of your thyroid and all other reasons there. Okay, just think that whenever the problem is primary hypothyroidism, class, okay, whenever the problem is primary hypothyroidism, the problem is the organ itself, the thyroid gland. Okay, so this could be congenital defects of the thyroid, defective synthesis of your T3 and your T4 because of the deficiency of your iodine. And then, it could be also because of your anti-thyroid drugs. Common anti-thyroid drugs are your propylthiouracil, and then you have your methimazole. Propylthiouracil is usually abbreviated as PTU. So they are the drug of choice for hyperthyroidism. But overuse of these drugs or overdosage of this drug would obviously lead to hypothyroidism. Your surgery could also result to hypothyroidism. Okay, the removal of your thyroid, okay, would lead to a sudden drop of your T3 and your T4. Then your radioactive iodine exposure also could destroy your thyroid. Okay, class, remember that our thyroid is fond of uh, taking in iodine. So even if it is radioactive iodine, okay, it would try to take it in, even it can destroy it, leading to hypothyroidism. Then you also have your autoimmune thyroiditis. If ever you're here with your autoimmune thyroiditis, of course, it's inflammation of your thyroid, which has autoimmune implications. It is also known as your Hashimoto's disease. Your Hashimoto's disease class would initially manifest as hyperthyroidism and then later on would become hypothyroidism. Okay? Then you have your secondary causes. For the secondary causes of your hypothyroidism, think of a problem in your pituitary gland. So this is because of the malfunctioning of your thyroid brought about by a problem in your pituitary gland. So we have a problem on the TSH, thyroid stimulating hormone. Okay, this could also be caused by peripheral resistance to hormones. When I say peripheral resistance to hormones, meaning there are adequate hormones being released. However, the body is not responding to these hormones. Then you have your tertiary hypothyroidism. In your tertiary hypothyroidism class, this is brought about by tumor or destructive lesions of your hypothalamus. So our problem in your tertiary hypothyroidism is your TRH, your thyrotropin releasing hormone. Okay? So again, primary, the problem is the thyroid itself. Secondary, the problem is the pituitary gland. And then tertiary, the problem is your hypothalamus. Any of these conditions may lead to your hypothyroidism. As a recap, if I talk about, for example, pituitary adenoma in a patient with hypothyroidism, this would be considered as a secondary cause. Okay, this is a secondary cause. Then, the decrease of your thyroid hormones would lead to generalized slowing of all physical and mental processes. Okay, physical and mental processes, they all slow down. Now, this leads to decrease of your cellular enzyme system and oxidative processes, meaning enzymes, cells are not working properly. There is metabolic activity decrease. There is a decrease of oxygen consumption. There is a decrease of oxygenation of nutrients for energy, meaning we will have problems with our energy sources. Then there is decreased heat production. That's why classic to hypothyroidism is your cold intolerance. Meaning, class, a certain amount of cold your patient will not be able to tolerate because the body is unable to produce enough heat to compensate for the cold temperature of the environment. Goiter. We know that goiter is the enlargement of your thyroid gland. Class, your goiter may manifest or may not manifest in hypothyroidism. Okay, take note of that. So meaning in hypothyroidism, the thyroid gland could be large or it could also be small. The enlargement of your thyroid gland is usually associated with hyperthyroidism. However, it may also be present in hypothyroidism. Then, for the pathophysiology. So take note that the thyroid gland would need in iodine to synthesize and to secrete its hormones. The lack of iodine or the suppression of the hormone production could lead to thyroid enlargement. This thyroid enlargement class is brought about by the attempt of your thyroid to compensate. Okay, it's trying to compensate. It will try to produce more hormones because it thinks that it's failing. It thinks that it's failing on its function. Now, with the enlargement of your thyroid, the problem would be the compression of your neck structures. Okay, so compression of neck structures would lead to problems such as your respiratory problems and then your dysphagia. How is that so? Recall, class, the location of your thyroid gland at its close association with the location of your respiratory tract and then your gastrointestinal tract. Okay? So, when the glands will become so large, it might compress the structures of the neck and then your chest. A respiratory symptoms and then dysphagia. Now, with the decrease of your T3 and your T4, there will be an overall slowing of your BMR. Okay? Your patient would have achlorrhea, Class, your achlorhydria is the decrease of acid production in the stomach. There will be a decrease of gastrointestinal tract motility, meaning your patient will be at risk for constipation. There will also be bradycardia. There is a decrease of neurologic functioning. There is a decrease of heat production, and there will be problems with lipid metabolism. Okay? The most important change, class, caused by the decrease of the thyroid hormone is your lipid metabolism. Because your body seeks energy, class, your body might metabolize lipids, okay? Leading to problems with our ketosis. Assessment findings in a patient with hypothyroidism. So class, because of altered fluid and electrolyte imbalance, the patient may have weight gain. There could be enlargement of the tongue. There could be hoarseness of voice. There is slurring of speech. Okay, remember, these are related to the decrease of your BMR. Then you have your exophthalmos. Class, your exophthalmos, or the bulging of the eyes, is prominent in hyperthyroidism, but it can also be seen in hypothyroidism. There is peripheral edema. There is fluid retention. The body is unable to secrete your excess fluids. Then, your patient may have menorrhagia, dry skin, coarse skin. There's decreased sweating, coarseness of hair, loss of hair, sparse eyebrows, brittle nails, and then decreased libido and fertility. Now, try to think. Why would my patient with thyroid problems have manifestations in the integumentary system? Okay, how come, class, that the patient would have dry skin, coarse skin, okay, loss of hair, sparse eyebrows, brittle nails? What could be the reason for these signs and symptoms? Then, decreased metabolic rate. Your patient would have decreased body temperature. There will be intolerance to cold, which I said to be classic in your hypothalamus. There is anorexia. There is constipation. Remember, your constipation is brought about by the decrease of your GI motility. And there will be yellowish discoloration of the skin. Then, because of decreased oxygen consumption, your patient would have pallor of skin and lips, okay, cold skin intolerance still. There will be bruising, bradycardia. There will be a decrease of blood pressure and decreased RBC production. Okay, so class, look at that. Because the body perceives that it is not using oxygen anymore, so the bone marrow will be triggered not to make a lot of RBCs, later on leading to your anemia. Then there is altered perception and coordination. Okay, you have generalized weakness, you have lethargy, slow movement, slow intellectual functioning. Okay, notice everything is down. There will be muscle pain, paresthesia, night blindness, and even deafness. Okay, class, related to the neurologic involvement because of the decrease of T3 and T4 and the decrease of your basal metabolic rate. Now, let's talk about myxedema, coma. Class, the term myxedema would refer to the accumulation of your mucopolysaccharide in the subcutaneous and other interstitial tissues. So again, when I say myxedema, it refers to the accumulation of your mucopolysaccharide in your subcu and other interstitial tissues. Now, when I say myxedema, coma, it is a severe hypothyroidism resulting in a decompensated metabolic state and mental status changes. Okay, so your patient, because of severe hypothyroidism, would have decompensation and then mental status changes. Signs and symptoms are the same as previously mentioned. So everything will be down. Bradycardia, poor appetite, loss of eyebrow hair. The thyroid is just enlarged to compensate. Then there is thinning of the hair or hair loss, and then puffy face. Then your patient would have myxedema, okay, because of the accumulation of your mucopolysaccharide in the subcu and other interstitial tissues. Your patient would have thickened, non-pitting edema of the skin. So take note, it's a non-pitting type of edema. Then, your myxedema coma is rare, but it's very serious. It is characterized by persistently low thyroid function, which can be triggered by acute illness, rapid withdrawal of thyroid medication, anesthesia surgery, hypothermia, and use of sedatives and opioid analgesics. Class, during an acute illness, the demand for the body, or the demand of the body, I mean, for energy increases. So the body perceives that there is no, okay, or there's a sudden, abrupt decrease of your T3 and T4. Then, rapid withdrawal of thyroid medications, okay, would also lead to a rapid drop of your T3 and T4. Your anesthesia and surgery, okay, class, the anesthetics may depress the neurologic system. Then class, later on, your myxedema could not be easily recognized because of the depression of the neurologic system brought about by anesthesia and surgery. Added to that, your anesthesia and surgery may also be considered stressors. Okay, so hence the higher demand for basal metabolic rate. Then you have your hypothermia. Okay, so cold temperature could trigger your your myxedema coma. Then, class, the use of sedatives and opioid analgesics would also lead to your neuro depression. Okay, neuro and respiratory depression for that matter. Then, so class, we have your myxedema still. So it's considered to be a true emergency. It's severely compromised hypometabolic state. And then class, you would observe the patient to be in progression from stupor going towards coma. So the patient has a tendency to become lethargic, obtunded, stuporous, and then later on comatose. Okay, so neurologic signs and symptoms are really prominent. Look at the assessment findings. Sensorium class would be decreased. Temperature would be decreased. Ventilation would be decreased in such a way that we might need to have a mechanical ventilator for the patient, okay, in positive pressure. The blood pressure would be decreased. Sodium and glucose has a tendency to be decreased. Then cerebral metabolism would also be decreased. Shock later on will occur. Okay, and then you will have death. Okay? Class, if you're talking about a patient with myxedema coma, okay, assume a patient admitted in the intensive care unit. So, here are the signs and symptoms if you're hypothyroidism. You may pause the video presentation, okay, for you to review some of the signs and symptoms. Okay, look at the late clinical manifestations. Subnormal temperature, bradycardia, weight gain. There is also decrease of the level of consciousness. Then you have your thickened skin and then your cardiac complications. Remember, class, that this affects your heart. Okay, look at that. You have bradycardia. Your bradycardia, remember, could also be considered as an arrhythmia. Okay, so class, later on, your patient may have AV block because of the failure of the heart to function properly. So this is alopecia in your hypothyroidism. This is exophthalmos, which is prominent in hyperthyroidism. However, could also be seen among patients with underactive thyroid gland. Then you have your myxedema of the hands, which is caused by the deposits of your mucopolysaccharides. Okay, so remember there are deposits of mucopolysaccharides in your peripheral aspect of the body. So you have your non-pitting edema for that matter. Then this is myxedema of your legs. Then let's talk about management. So class, for the management. So for hypothyroidism, we manage your hypothyroidism with your drugs. So you have your leothyronine and your levothyroxine. Just think, class, thyro, meaning they contain your thyroid hormone. So they are used for hypothyroidism. Side effect, hyperthyroidism. Meaning, class, if your patient is being treated for hypothyroidism, you need to monitor them for possible recurrence or occurrence, I mean, of hyperthyroidism. Then you have your desiccated thyroid. Try to pause the presentation and try to find out what is a desiccated thyroid. Class, your desiccated thyroid, okay, is a thyroid extract. It's a thyroid gland that has been dried and powdered for medical use. Okay, it's used to of course, to manage hypothyroidism. However, with the onset of the use of levothyroxine is commonly used already rather than your desiccated thyroid. The class, for your desiccated thyroid, take note that the maximal effects may take up to 3 weeks to occur. Okay, so you educate your patient if ever they're using this drug that they do not hurry because, class, the effect may be 2 to 3 weeks. Then, for dietary management, okay, as mentioned earlier, your body, your thyroid needs iodine. Okay, iodine for it to produce the T3 and T4. So class, a very good source would be your iodized salt for that matter. Then food sources, you have your fish, okay, especially your cod and tuna. You have your seaweed. You also have your shrimp. Okay, so these are the seafood that could probably have rich sources of iodine. Your dairy products class, such as your milk, your yogurt, and your cheese, also contains iodine. Then surgery is indicated if your patient would have a very large goiter. Okay, so thyroidectomy is done. But class, be mindful as nurses, when thyroidectomy, is done, okay, you need to watch out for signs and symptoms of parathyroid problems. Because again, your parathyroid gland is located behind your thyroid gland, which could possibly lead to the accidental removal or accidental stimulation of your parathyroid gland. Then, for myxedema coma, your priority will be airway. Remember, we're talking here about respiratory and urologic compromise. So ensure that your patient would have patent airway. Okay, so supplemental oxygenation may help. You need to have IV fluids for this patient. And then the drug of choice will be your sodium levothyroxine to be given with glucose and corticosteroid IV. Okay, so you have your levothyroxine with glucose and corticosteroids. Now class, try to think. Why do you think is your levothyroxine given with glucose and corticosteroids? Okay, let's answer that question during your live discussion. So what are the possible nursing diagnoses for this patient? 1. Activity intolerance. Due to the decrease of basal metabolic rate, your patient could not tolerate simple activities. Impaired physical mobility, again because of the decrease of basal metabolic rate. Other than that, your patient is also experiencing muscle pain. Okay? Then you have your altered nutrition, more than body requirements. Self-care deficit. Impaired thought process related to the slowing of your mental processes. Then altered body temperature, usually that would manifest as hypothermia. And then altered bowel elimination patterns. Okay, altered bowel elimination pattern is related to the decrease of your gastrointestinal tract movement. Hence, class, the common manifestation is constipation. On the succeeding discussion, we will be talking about your hyperthyroidism. Thank you very much for your attention.